everyone. Welcome to LDI's virtual panel on coronavirus vaccines, addressing challenges in distribution and uptake. I am Rachel Warner. I'm LDI's executive director. Today's conversation is obviously very timely. The coronavirus vaccines have been developed in record time, and now we have a couple vaccines under review by the FDA. But we face another enormous challenge with the vaccines, which is making sure that the people who need them get them in a way that is equitable and fair. So I'm very excited to have today's panel with us today. We have an all-star lineup of people. So we have joining us today Dana Bowen Matthew, who is Dean and Harold G. Green Professor of Law at George Washington University Law School. Dean Matthew is a leading expert on health equity and public health policy and has advised the CDC on ethical issues in the distribution of the COVID-19 vaccine. Nicole Lurie is strategic advisor for the Coalition of Epidemic Preparedness Initiatives, the largest developer of coronavirus vaccines outside of the United States. In the Obama administration, she served as the Assistant Secretary for Preparedness and Response at the Department of Health and Human Services, where she led the response to public health emergencies ranging from infectious diseases to natural and man-made disasters. Paul Offit is Director of Vaccine Education Center and Professor of Pediatrics at the Division of Infectious Diseases here at the Children's Hospital of Philadelphia. Dr. Offit is an internationally recognized expert in virology and immunology and a member of the FDA's Vaccines and Related Biological Products Advisory Committee. We're also joined by Caroline Johnson, who is Deputy Health Commissioner for the City of Philadelphia and Acting Director of the Division of Disease Control for the Philadelphia Department of Public Health. Dr. Johnson serves as a liaison to the city, state, and federal agencies for joint planning in response to public health issues. He is currently leading the city's planning for the distribution of the COVID-19 vaccines. And then today's panel will be moderated by Allison Buttenheim. Allison is the Director of Engagement at the Leonard Davis Institute of Health Economics. She's Associate Professor of Family and Community Health at the School of Nursing, Associate Professor of Health Policy, and Scientific Director of the Center of Health Incentives and Behavioral Economics. She is a public health researcher and behavioral epidemiologist who focuses on improving child health and increasing vaccine acceptance. And she recently served on the National Academy of Sciences committee that developed the framework for equitable allocation of the COVID-19 vaccine. So thank you all very much for joining us, and I'm looking forward to the conversation.
Thanks very much, Rachel. This is an event I've been looking forward to for a long time, having these four experts in the Zoom room, in the Blue Jeans room, to talk about vaccine acceptance and all the other aspects of rolling out the COVID-19 vaccine. So here we are in December after an extraordinary year of disruption to our routines and our plans and our daily lives and our economy. Many lives lost, many folks today being diagnosed and in the hospital, and a strain like no other on our healthcare system and healthcare workers. And since the pandemic took hold earlier in the year, we've had the promise on the horizon of a vaccine, and suddenly here it is, much closer, perhaps just days or a couple of weeks away. Which really begins our route back to normal, hopefully. But the incredible speed with which they've been developed really is just the start of a longer journey. So today we're going to follow the journey of that vaccine from its development to approval. Because it will be in limited supply, we have to think about its allocation across and within populations, and then of course its distribution, delivery, and acceptance. So I will do a round of our panelists in the order of that journey. I'll start with Paul. The panelists have invited me to use first names today. Paul, you sit on the Vaccines and Related Biological Products Advisory Committee, which I always have to look at the name for. I think of it as VRBAC, which will be meeting next week to perhaps provide EUA, emergency use authorization, for the first vaccine, the Pfizer vaccine. Can you just give us a window into where we've come so far with vaccine development and what's going to happen at that meeting next week, and where we might be a week from now with actually having a vaccine in hand?
Right. So it's pretty remarkable when you consider that there was an article published in Science in January 2020 that was the first then description and sequence of the genome of SARS-CoV-2. That roughly 11 months later, you have two vaccines which have virtually completed their phase 3 trials, one 30,000 participants, the other 44,000 participants, with vaccines that look to be highly effective, at least from the sort of top line data that one sees in press releases. We're still sort of in the science by press release age, but certainly we will look much more closely at those data at the FDA's Vaccine Advisory Committee meeting. But you know, what looks to be true is that these vaccines are 90 to 95% effective, that the efficacy seems to extend to people who are over 65. The efficacy extends to people who have protection against severe disease, without any, at least apparent, important or major safety concern. Again, we need to look at those data, and we will. But as it stands right now, Pfizer's application for approval under EUA will be considered on December the 10th. The ACIP, the Advisory Committee for Immunization Practice, the CDC will soon follow. It's expected that it's possible that vaccine could start rolling into the arms of the American public as early as December 15th. That same week, December 6th, 17th, we will consider Moderna's application. ACIP will soon follow, and it's likely that could be out as early as December 22nd. So by the end of this month, these vaccines will be given at least to the 1A group, which is considered to be people who either work or are residents of long-term care facilities, as well as essential workers, i.e. healthcare workers that have direct patient care. So I guess that's the lay of the land. I think just the one other thing I want to add is it's too bad we use the word emergency use authorization, because I think that confuses people. I mean, at least when I think emergency use authorization, I think hydroxychloroquine, which was approved under an EUA, even though it hadn't been shown to work and frankly was unsafe. Convalescent plasma, which at least at that point hadn't been shown to work and was billed as sort of a major breakthrough. And I think people worry that the same sort of loose criteria would be applied here. I mean, these size of these vaccine trials are the size of any vaccine trial, really. I mean, the human papillomavirus vaccine trial was a 30,000 person trial. The rotavirus vaccine we worked on at Children's Hospital Philadelphia was a 70,000 person trial. So these are roughly the same size. The only difference really is length of time that you're following up efficacy. You're only going to know these vaccines are effective, for a couple months when you release it. So that's the if you want to use the word risk, but that's the thing that you need to follow. But I do think if something is highly effective within a couple months, it's likely to be at least significantly effective 6 months or a year later. But that will be looked at. That's the risk. The safety thing, I love what Commissioner Hahn did. He said we want 2 months safety data after the last dose. I mean, if you look at the serious side effects associated with the vaccines, usually they're picked up within 6 weeks. So you can say at least you don't have a serious adverse event now. At least it's relatively uncommon. And then with 20,000 people isn't 20 million people. We'll know about whether there's a rare serious adverse event once it's out there, but there are systems in place to pick that up. So that's what I would say. That's summarizing 1 year in 4 minutes. Thank you.
That's amazing. It was an amazing summary, and it's been an amazing year. Obviously, developing these vaccines orders of magnitude faster than has ever happened before. Dana, let me turn to you. So even with this extraordinary rapid development and approval and the fact that there are multiple vaccines, we will still have limited supply for a while. And that means making some hard allocation decisions about who's in line first. You were one of the co-authors on the Advisory Committee for Immunization Practices framework for allocation. And it looks like you all prioritized from a sort of a principle standpoint, maximizing benefits and minimizing harm, promoting justice, mitigating inequities, and promoting transparency in that process. Some convergence around the idea that healthcare workers, frontline workers are at the head of the line, and also some combination of high risk, older adult, congregate living settings also having priority. But also some really interesting conversations about how allocation might take into account disproportionate burden, including racial ethnic disparities in risk and burden from the disease. How did ACIP sort of talk around those issues, those allocation issues?
Yeah, Alison, I was honored to be a part of the ACIP discussions, and I'm going to just be very transparent about our transparency. I was reluctant in the very beginning to join because I wanted to speak very frankly about race and ethnicity. I wanted to speak very frankly about disproportionality by race and ethnicity and socioeconomic status with respect to exposure to the virus, and I wanted to be really frank about that. And I just didn't know if the group was going to be, well, they were. We have been. And we've had I think, very difficult conversations, not unanimity, not easy answers or the questions, but the questions have always gotten asked. So, for example, Allison, you know, of course, that the prioritization around healthcare workers, to say healthcare workers is a broad category, right? And we could all agree, just like, you know, we like apple pie and baseball, that we think the healthcare workers and the frontline workers should get the vaccine first. But of course, it's more nuanced than that, right? My husband is a healthcare worker. He's a cardiovascular surgeon at a community hospital, and because he is one of only 2 surgeons in the hospital right now in his specialty, he is completely sequestered from the COVID virus patients. So as their census goes up, he gets further and further away from those patients. Now, I am really glad about that. But the CNA worker who goes in at night, and even the person who cleans the floor in the hospital for COVID patients, is also a healthcare worker. And it's unclear, and we had discussions about that, it's unclear in my mind, as much as I love him, why my husband should get the vaccine as a healthcare worker before the person who has exposure daily, maybe the food service worker. So there are still a lot of unanswered issues, certainly with respect to social status and exposure. And we had those hard discussions, not easy answers. And that's why the justice element of our framework is so important in my mind, because it doesn't simply look at the ethical issues of mitigating harm and being transparent, which are all easier for us to agree to, but it looks at equal opportunity. That's the sort of gravamen of justice, and it looks at it on a systemic or structural level. Not just is that person's job or occupation one that makes them individually eligible for prioritization, but as a population group, is it equal for population groups who are vastly more exposed to the virus to also be prioritized in terms of its treatment? I'll just end by saying this. I can think of categories, several categories that I could use. Sometimes I use transit workers. Today, I think I will use agricultural workers. So agricultural workers in the West are largely undocumented people of color. Immediately before the virus hit, undocumented workers had maybe guest passes, and they were in the shadows of our economy. They were driving slowly to make sure that their taillights didn't cause them to get stopped. And in an instant, in March, we become convinced that they are essential workers so that we can have our avocados and our citrus fruit delivered to us at the door while we shelter at home in front of screens. This is an ethical quandary, and we did talk about it. So the question of essentiality, what is essential? What does essential worker mean? I think is engaged and interrogated by the justice prong of our framework. So it did address it. We did have those conversations, frankly, and when I come around again, I'll talk about the race aspect as well.
Great. Thank you. And thank you for your service on that committee and for bringing those issues front and center. You know, once we make these allocation decisions, we actually have to get vaccine out to service providers and to jurisdictions. Nikki, that's a challenging factor at any moment. It's particularly challenging right now given the pandemic and, of course, given things like the cold chain requirements of these vaccines and storage issues. How will this work, and how vulnerable is our system in the US, if you want to speak about globally, on just the logistical side of distribution?
Well, one of the things that's going to characterize these first vaccines, as I think we all know, is they have really substantial cold chain requirements, and also that the vaccines are just in incredibly short supply, right? And in fact, the initial supply, I think, is a lot less than any of us anticipated it would be. And so one of the things that means initially is that the vaccine will be distributed to or dropped off at a fixed number of locations that are probably capable of high throughput for the phase 1A populations, or let's put it that way, is the goal. I think once we get beyond those fixed numbers of locations and that easy phase 1 or not so easy, but the phase 1 locations. It's going to be really complicated. I don't believe that there's been adequate planning done for it. I don't think the information systems are all linked up, et cetera. And one of the, in addition to even at a phase 1 site, and I want to talk about this for a minute, following up on Dana, thinking about, well, who actually in your hospital facility or your nursing home or whatever gets those limited numbers of vaccine. In DC, we're getting something like 6%, enough to cover 6% of frontline healthcare workers, let alone not all the nursing home residents. How do you figure out who those people are? And is that something that's left to a state level, to a local level, to an individual facility? You know, we've had a lot of discussions about, well, do you allocate by the burden of disease that each hospital takes care of? Do you allocate by the vulnerability of the population that the hospital takes care of? All of those things are really hard. But the other thing that I just want to really stress for this audience is we're looking at Congress trying to pass a bill that's going to provide financial relief both for Americans who have lost their jobs, who need to be able to stay at home and quarantine and all of those things, but also to pull off a vaccination campaign. And for people to have a real clear understanding that money has to go from Congress through the federal government to state governments to local governments through contracts to hire vaccinators and all the people who are going to represent the workforce to actually pull this off. It's not straightforward. It's complicated. Many state legislatures and local governments need to convene to approve contracts and spend money. I don't know what it's like in Philadelphia. Carol can tell us. But all of those things are complex and take a long time, and you can't spend money you don't have. So the planning components of these things have been really challenging. In past administrations, and I can speak from my experience in H1N1, you know, the federal government entered into a really strong partnership with governors and mayors. The planning went on for months. There were templates, there was technical assistance, there was a lot of effort to create a consistent framework at the federal level, not just for allocation, but for how all this was going to happen, and then to have state and local governments adapt it as needed. I feel like we're way behind in all of those efforts here, and the fact that money's not available puts us further behind. So I imagine that the beginning of this is going to be pretty chaotic, and I imagine, just based on even events in the last 24 hours, that a lot of places are going to be expecting a certain amount of vaccine, and they're going to get a lot less. And that's going to be frustrating for all the planners, then people have to pull off a vaccine, and it's going to be really frustrating for people who really want that vaccine early.
Whew, okay, an optimistic view. Nikki, I think it's really important that you raised the idea that, you know, we have federal response, but this all happens at the local level. For vaccines, that happens at the level of our jurisdictions, of which we have 64 in this country. Most are states. Some, like Philadelphia, are cities and territories and DC. So, Carol, you know, the city of Philadelphia is at sort of the end of this chain of allocation and distribution. Can you tell us how this works at the level of a city that's going to take allocation and try to figure out how to meet, you know, large demand with limited supply and, you know, without yet, as Nikki's pointed out, maybe as many resources as we'd want from the federal government to make it happen? So where are we in Philadelphia, and how are you going to carry out this enormous endeavor?
It's always great being the last speaker on a panel because everyone else has done such a great job sort of laying the groundwork for this. I'm just going to start off by saying, well, our planning started in the summer because we knew that vaccine was coming. And the very first step was to convince everyone, including my co-planners and other people in the city, that it was not our job to determine vaccine efficacy and safety. And it was not our job to figure out what the recommendations were going to be. You know, back in August, that's all people asked me, is it going to be safe and effective? And I, you know, spent a lot of time saying, FDA will tell us if it's safe and effective. ACIP will tell us what the recommendations are. So, you know, we really had to get our whole team to sort of focus on, you know, our job is distribution. in the city of Philadelphia, and how do we do that in accord with all the other guidelines and issues that have been brought forth outside of our jurisdiction. So one of the first things that we did was convene our Vaccine Advisory Committee, of which Allison is very kind to serve on for us. But we brought together people who represented the vulnerable populations, the groups that we thought were most likely to be vaccinated first, people representing businesses, healthcare, aging population. So we convened all of them, and we wanted to make it clear that we heard their voices, we heard their needs, and we wanted to be very transparent about it, that there was not going to be any secret handshakes behind the door. So that was kind of the first step, was to convene this committee, and we've been meeting every 2 weeks since September. And he's been very helpful about bringing things to our attention and passing, giving us on some of our communication work and things like that. But to talk about the planning process, the first part of our planning process has really been focusing on what we've been calling phase 1, which is getting vaccine into the highest priority groups, such as healthcare workers, long-term care, essential workers. And so we needed to catalog that in a way, figure out how many there were, where they were, who they were, and how we were going to access them. So that was a great part of the early planning, was getting these counts and trying to figure out which agencies we could use to get to that particular group that was high priority. And as it's been said before, healthcare workers are clearly number one on this list. We've been actively engaged with hospitals from the very beginning. And matter of fact, yesterday, most of the health systems in the city received a phone call that told them what their initial allocation was and what we thought a start date was. So we're really very involved, and we're kind of at the point of I'll say, pulling the trigger on the program, knowing that there still could be delays and other things. But we've been very actively involved with healthcare institutions and getting everyone ready for what's called this phase 1A. I will just make a comment about prioritization within phase 1A, because it was a topic that we struggled with a little bit. We thought that our hospitals and healthcare systems would be interested in standardizing prioritization, or what I'll say is sub-prioritization. As Dr. Lurie had said, some of the places are only getting 10% of the vaccine they need to do their whole workforce. So clearly you have to sub-prioritize within healthcare worker groups. And we thought that hospitals would want to do that in a similar fashion. But as it turns out, I think that the needs and the observations in the different facilities suggest that they need to make this as an internal decision. So we have heard from some groups that their highest risk are in trauma surgeons, which I would not have guessed, but apparently is a very high risk. Others are prioritizing obstetrical services. So we have not, as a city, we have not established what those sub-prioritization groups should be. We have encouraged the health systems and hospitals to do that internally, and we will weigh in as asked, but it appears that most of them are fairly comfortable with determining this within their own agencies. I think I'll just end there.
That's really interesting, and I have a follow-up question for you later on sort of the equity implications of that. The last step along this journey is getting this vaccine in arms, which, for many people, I'm sure they'd stand in line today and get it. But of course, we're going to have lots of folks who may be less enthusiastic or even hesitant or concerned about the vaccine. And what I want to do next with the panelists is ask each of you about a specific form or type of vaccine hesitancy we might anticipate and your suggestions for strategies to address it. Paul, I know you've worked on vaccine hesitancy for a long time, but given your role in VRBPAC, I'm wondering if you can speak to people's concern that the speed with which these vaccines were developed might mean them, mean that they're less safe, or that they want to wait and see, everybody else get it first. How do we address that concern?
Well, and it's an understandable concern. I mean, this is the fastest developed vaccine in history, and it's being, and the strategies that we've used, messenger RNA, the first two that are going to come out, are something for which we have no commercial experience. So I understand the hesitancy. The reason it's been fast is that basically the government took the risk out of it for pharmaceutical companies for the most part. Not all pharmaceutical companies, but some of them. So the government said, we'll pay for phase 3 trials, which cost hundreds of millions of dollars. We'll pay for mass production of the vaccine, not knowing whether it's safe, not knowing whether it's effective, and that if either of those things isn't true, we'll throw out hundreds of millions of doses. No company would ever do that. So I think that's largely the reason it's been so quick. I think that in terms of sort of dealing with the hesitancy, again, I think most people are concerned about safety. Most people are going to be healthy young people that are going to get this vaccine who are unlikely to die from it. But again, we are testing the water with one foot here. This is a limited edition vaccine, if you will. It's the Beanie Baby of vaccines. There's going to be millions of people who will get this vaccine, before the general population are going to get it. Actually, tens of millions before the general population gets it, which means that you're going to have a huge safety profile to look at. So I think that you should be reasonably skeptical of vaccines. I think you should be skeptical of anything you put into your body, and you should ask to see the data and be convinced of those data. Be convinced, as Dana I think was alluding to earlier, that you're in these trials. I mean, that if someone over 65, it's a particularly racial or ethnic background. If it's people who are overweight, people who have diabetes, whatever, that you feel comfortable that you are represented in these trials. I think that's going to be the challenge. That's different than the vaccine cynic rather, where the anti-vaccine activist is not someone, is someone who just frankly believes there's a big conspiracy to sell vaccines, that pharmaceutical companies control everything. They are not convincible. I mean, if you've, as I think many have said, Neil deGrasse Tyson especially, he says, if you've reached your conclusion without using reason or logic, then reason or logic is not going to talk you out of it. And I think that's where we are with the anti-vaccine activists.
Yeah, and I think with limited resources to devote to promotion and acceptance, the anti-vax group is maybe not where to put our first dollars. Dana, let me return to you. And when we survey residents in the U.S. about their willingness or intentions to get the vaccine, one group that's reporting pretty low intentions at this point compared to other groups are Black Americans. There's certainly some justified distrust there, long history of medical exploitation, unconsented experimentation, a feeling that maybe this health system doesn't have my interests at heart, and it's a group that I think a lot of people are thinking about how to message and how to support in taking advantage of this vaccine. How are you thinking about that? What strategies come to mind?
Well, I have a set of strategies in mind that range from pretty neutral, pretty acceptable, to pretty radical, quite frankly.
Let's hear the radical ones.
Yeah, I'll get to that. I just want to set the table by saying, this is a structural problem that is totally predictable, right? If you think about this and put it into its most basic elements, we have nothing new under the sun happening here, right? From the perspective of the disproportionate morbidity and mortality, nothing new under the sun, right? All of the things that predispose Black and brown populations to disease are the kinds of disparities that showed up in the COVID hospitalization and death. All of the things that make it unlikely that Black and brown populations will uptake this virus are entirely predictable for many of the things that you, Allison, just said. And so one of the things that I want to highlight is the ethical, I'm going to go ahead and be radical, the untenable ethical position that we could have as a society, a totally predictable known problem, a totally avoidable problem. In other words, we're talking about a 90 to 95% effective treatment for a known severe outcome, like death is the outcome, and we don't systemically and structurally address the racial and ethnic disparities that we can predict right now, right? So the notion, I understand and appreciate so much what Paul was saying, but the notion that I as an individual should be looking behind the research curtain to make sure that I am in the trials is somewhat, I think, a burden misplaced. The way that I have been excluded as a Black and brown person from the trials is systemically, is structurally. It is by the industry, it is by the scientists, it's by the research, it's by the hospital, it's by the system. It's remarkable to me that we are comfortable thinking specifically about race and ethnicity when the problem occurs, right? So the fact that you are in a socially undesirable housing setting that's densely populated and you're more likely to be exposed to the disease, we're okay with racial segregation being the mechanism by which that disparate exposure and I would say comorbidity, if you will, occurs. We're fine when it's education. Educational segregation is rampant in this country, and we're okay with the mechanism being race. We stop short, though, when the disease remedy should consider race. So the radical thing I think we should consider is the race and ethnicity and disproportionality of that population in their exposure to the disease, exposure to hospitalization, and exposure to death. Right? But we don't want to do that. Right? Because I'll quote a jurist, because the way to stop discriminating based on race is to stop discriminating based on race. That is the most simplistic and, in my view, morally untenable approach to addressing the problem that I've described, that's severe, that's predictable, and that's avoidable. In a sort of milder term, if you don't want to say, the same population that got the disease disproportionately, that we depended on disproportionately to stock our shelves, to drive our buses, to deliver our papers. If you don't want to do that, if that's not, then the proxies work. Right? Because we have such structural disproportionality, then we could do also mild things. We could make sure that we have community health workers. We could make sure that pre-education is targeted to populations. We could talk about access. We can make sure that the people that are distributing it are not like our current administration suggested military or militarized people, but instead people who speak the language of those who might be trusting of their neighbors, and so on and so forth. So there are very deliberate things that we could do. But again, I guess I want to be a little bit of a provocateur and say, why are we so cautious about talking race and ethnicity when we talk about allocating good public benefits, and less so when the burdens are distributed?
Amen. That is really thought-provoking, especially given that the different allocation schemes that have come out have addressed that issue more and less carefully or cautiously and not as explicitly as you've just called it out. Nikki, maybe that's a good segue to a question to you about hesitancy that might arise around the politicization of vaccine development, the politicization of the pandemic. Political party is one of the big divides we see in survey data about people's interest and willingness to get vaccinated. You have been at many levels of government and observed this. How do we depoliticize the rollout of this vaccine and alleviate people's concerns about a political vaccine?
Yeah, isn't that the question in the moment, Allison, for sure. Let me just come back for one quick second to something Paul said in the beginning about vaccine development, because I think it's germane here. And when I hear all of this stuff about, this was rushed and it was at warp speed and, we've got the current administration doing X, Y, Z, one thing I think that's really important to keep in mind is that for the past decade, scientists have been working on developing and perfecting mRNA vaccines. It was after H1N1 that we all decided we need to move from a one bug, one drug approach to platform technologies like mRNA. And so these things really aren't brand new. They've been 10 years in development. And I think it's really important for people to understand that over 10 years, they've gotten the bugs out to the point that we've been able to do what's happened so dramatically in the last year. And I think that's important because that also spans a number of different administrations worth of efforts, just on the political side. I think And I'm hoping that, we're going to be able to make pivots on a number of different levels with regard to these issues about confidence and skepticism and politicization. One of the things that I think's happened, first of all, is there are so many concerns about how politicized the FDA was and the approval process has been. Paul talked about EUAs on the drug side. I think the FDA has done a really nice job, sort of with a lot of help, but clawing back to a position of scientific integrity and following the science, even as we watch the approval in the UK this week, and FDA saying, wait, we're going to go through our process, we're going to have a VRPAC, we're going to get advice from scientists, then we're going to make our decision, and we're going to take however long it takes to be sure, America, that this vaccine is safe, is really, really important. And as I think then, as we move into a new administration, obviously there will be different kinds of politics, but I am hoping, and I think a lot of people are making efforts to stop being this, to stop this being about Democrats versus Republicans, or wearing a mask or having a vaccine as a test of your religious faith, to really some better concept of the ways in which, we're all in this together and the vaccine is the enemy. But at the end of the day, people take advice and guidance from people they know and trust. And we know that. And so we know that the message can't just come from our political leaders, and it can't just come from our scientists, but it has to come from people in all of our communities all over the country. And I think it's why Carol put together this committee. Philadelphia, we did the same thing in DC, and to start to identify who those trusted people are on both, in any political party, of all races and ethnicities, of all social classes and social status, of all different, language speakers, all of these things, so that we can do our best to reach these populations. And then I think very consistent messaging from the top is going to help. It's not going to take care of it all, and I think we've already talked about the fact, there's a proportion of the population that's not going to step up right away and be willing to get vaccinated, and Allison, you and your colleagues do a lot of work in behavioral economics and others, and it's going to be really interesting to think about what are the behavioral economics approaches to help people make choices to get vaccinated. But I'm actually optimistic that we're going to be able to move beyond some, not all, of the politicization. And if you figure that, a lot of people are going to die between now and January 20th. The situation is going to be even much more dire, than it is now. Some places may reach herd immunity, I'll say tongue in cheek, but I think that we're going to see increasing motivation. We're also going to see other countries around the world using this vaccine, and I think that that's going to help as well.
That's a great response, and actually a great segue to the next question I wanted to pose to Carol, which brings in this idea of trust. And I was really intrigued by what you mentioned about the sub-prioritization, and at least in Philly, each sort of health system determining where vaccines go within the building. Wondering if that's a potential source of public confusion or distrust, or appearances at least of, is this fair? How is this fair? How did this surgeon get it before this, food service worker at this hospital? Any concerns? It sounds like you all said, okay, that, health systems go do your sub-prioritization, but are you worried about the public trust side implications of that?
I don't know that we've heard anything along that line. I think it is primarily because the health systems have taken an approach that is not based on job title. So they are not going in and saying we're doing our nurses first, our doctors first, or whatever. They're going in and recognizing the sort of physical areas where the risk is great, for example, in emergency departments. And they are capturing all of the employees that serve supportive roles. So that includes security, that includes food, facilities, communications. And so I think the way that they're approaching this does create a vision or a view from the public side that, okay, everyone who works in the emergency room is eligible, and that it does level the playing field a little bit, that it's not based on what kind of degree you have. So I think that is going to be more reassuring to the public. Now, I will just go on because I'm interested in this health equity topic and just touching on the city's approach to that.
Yes.
And what Dana had said, is really key. How we distribute vaccine locally is how we achieve that sort of health equity. And when we talk about health equity, we're treating this as creating health advantages. So how can we promote uptake by persons of color by creating advantages for them to access vaccine? And so what that looks like in Philadelphia could be very different elsewhere, but in Philadelphia, that means things such as where we go with our vaccine. We know we have to set up clinics that we'll be running ourselves or partnering with people. And we intend to go to the communities of color and communities that have been hit the hardest with vaccine early. It also, by partnering with people who are known to serve communities of color, or respected by communities of color, or trusted by communities of color, I think that we can create some promotion of the vaccine as well as creating opportunity for them. So in Philadelphia, we have the Black Doctors Fighting COVID group, who everyone knows, Dr. Stanford's group. And, they'll be one of the first to receive vaccine to push out in accord with what our phased plan is. One of the ones that you'd like controversial things, Allison, I will throw you out where I'm really pushing the limit, and we'll get criticized about this, but it is one way that we can create these advantages. And it has to do with exploiting our jurisdictional limitations. So the way the vaccine allocation plan worked, it was population-based per capita. Philly gets X amount of vaccine for their population size. When it comes to a city, that's not really fair because we know that most people work in Philly and healthcare is all in Philly. And so it's kind of draining our supply because we're going to be doing all the suburban counties. So one of the things that I believe that we will be doing when we are in what we're calling the phase B and is dealing with essential workforce is that we are going to be absolutely strict about only immunizing Philadelphia residents. And that is actually one way to create some potential advantages to persons of color, because most of these essential workforce employees who are living in Philadelphia are persons of color. So we will, that is one way I believe that we can actually get this vaccine into the communities who need it most and create some advantages. I say that we will be criticized. I don't think anyone's going to criticize us from a political standpoint because the Philadelphians will want the vaccine in Philadelphia. But those employees that we're turning away because they live in a different jurisdiction will not be happy about this. And so we're prepared to face some of that. But, it's really important to us to make sure we're getting this to the right communities. And we're really hoping that our partners will help promote this and, be our sort of our beacons of light to the communities to get the vaccine there.
Great. Thank you. There are, by the way, about 400, not that many, but an amazing set of incredible questions coming in that I wish we had like 3 more hours with this panel to address. But several of them refer to the fact that we may have multiple, probably will have multiple vaccines available. There's curiosity about how that works at the individual level. Do I have to choose which vaccine I want? But also from the sort of logistics and distribution, how do we handle this sort of bounty of available vaccines from all the different angles that you all are working? And I'll let anyone jump in there who has thoughts about that.
Well, I might jump in and say this is, an issue for the U.S. It's also an issue for the work that I'm doing globally, right? Mm-hmm. And so there's still a lot about a number of these vaccines that we don't know. So we have to look, first of all, at how effective they are. Some may perform better in some populations than others. Right? And so you'll want to see if you can match efficacy as best as you can to the population. Some may be 1 dose instead of 2. Some may have different durations of immunity. Those are all kinds of things we don't know. Some you might feel better about administering to pregnant women, for example, than others. And so a lot of things there that we don't know. But I think in general, the sense both globally and I think in the US is it's going to be a lot easier for jurisdictions to handle a limited number of vaccines instead of vaccines. And even I can tell you, thinking back to H1N1, when we just had a couple different vaccines, it was pretty hard and pretty confusing. So that will be a little bit worse, a little bit more complicated. There is some sense in some areas about asking jurisdictions in some sense to make some choices about what they want to have. And those choices are also, I think, going to be informed by what I call the usability. So not every place in the country can handle this cold chain very easily. So probably the cold chain vaccines are going to be preferred by people in dense urban areas, or health departments in dense urban areas, as opposed to in remote rural areas where it's going to be hard to get them there, and you might not have enough people to vaccinate with a box full of vaccines. So that's going to be, I think, an easy determination point. What's happening globally is that there's a concept that countries will be able to talk about what's most usable for them and most desirable for them in one way or another, but also that there might be an exchange. And so if I'm allocated, 100 doses of A, B, C, and D, and they're all about the same, and I only want A and B, and somebody else wants C and D, we may be able to trade. And so there are a whole bunch of people really working now to set up that exchange globally, which is quite interesting and maybe a little more of a conversation. So sort of interesting, sorry about that, about sort of market exchange rates and those sorts of things. But I imagine we're going to have to see some trading back and forth once we understand more about the populations that these vaccines work the best in and are most suited to.
Great.
And frankly, I hope that we're really in a situation where we've got a lot of different. I think we could be in a cold chain situation for a lot longer than we think. So we'll see.
Any VRBAC or ACIP or city perspective on the challenge and opportunity of multiple vaccines?
Yeah, I'll chime in about the city, and Nikki's absolutely right about this. We've already heard that many of the large rural states do not want the ultra cold vaccine. But so far, the allocation strategy has been completely population based for the 2 vaccines that are really expected to come out first. There's been no shifting of them around. But we know from history what will happen is some of those rural states will make a phone call to us and say, can we swap out 5 million doses of this vaccine for that vaccine? And then it becomes up to us to decide whether we'll do it or not. And I can't tell you what the answer to that question is. Our particular philosophy in Philadelphia has always been to make all vaccines available to our providers. So we don't influence. We try not to influence which vaccine they choose. We tell them up front, this is the vaccines that are in our stockpile for you to use. You can order as the doses that you want, and if we can fulfill them, we will. So we do not pass down any preferences about vaccines. We just make available what we have, and then when they're gone, and so on. So the one thing that we are pushing our providers to do is the whole problem in making sure that they get a second dose if a second dose is required, and that it's the same vaccine. Is we are pushing them very hard to say, you must give that patient their follow-up appointment with a date, with a time, with a dose, what they need when they leave after dose 1. So that's kind of where we're going with this, is telling the providers to be very meticulous about following up to get that second dose in, which is so critical. I have I believe our providers are going to say, I want to use one vaccine, because I think handling too many will be complicated. So we expect most are going to come back and say, I'm going to work only with this product. But that's yet to be seen for sure.
And you raised the challenge of the 2-dose regimen, which there were a lot of questions about as well, both how do we track that and make sure people have gotten the second dose, but also how do we convince people if the first dose doesn't feel very good, I keep thinking if it's as bad as Shingrix, that might be pretty challenging, but just make sure behaviorally people are coming back for that second dose. It's going to be tricky. We are rapidly approaching the end of the hour, which is tragic because there are so many great questions. But I do want to do a couple lightning rounds with just a one-sentence answer. And the first one is you've got one ask of the Biden-Harris Mission Team COVID Task Force for something to make this program a success. What do you ask them for?
I'll go first. I asked them to talk to Carolyn Johnson because the intentionality, no, seriously, the intentionality with which I hear the Philadelphia program addressing the equity issues is remarkable. There's a one sentence, period, done.
Paul.
Sure. I'm actually on the advisory committee with Rachel Levine, who's our Secretary of Health at the Commonwealth, and I think she has a pretty good plan for how to get vaccine out there. Well, what she needs is money, especially in areas like the rural areas where people are sparsely located. Where you may not be retail pharmacies nearby. You may need to set up a center in much the way you would have a testing center, and so she needs money. And I just think the federal government needs to meet her there.
I will echo those comments. Funding is what the city of Philadelphia needs. And you may or may not know, but the funding to come for vaccine distribution has been trivial so far. The CDC has given some funds out through their immunization grant, but it has been nowhere close to what we really need to run these programs. So that's my request.
Great. And Nikki?
Well, I would put money number one as well. And I think the other thing I would say is don't overpromise and underdeliver.
That the committee should not the federal government should not overpromise and underdeliver.
Right. None of us should. I think we have to be really realistic.
Humble. The last lightning round question is going to have us cast our minds forward to December 4th, 2021. And if you look back on the year we've just had, what would you like to be able to say went well with the vaccine rollout? What success would you like to claim? Go, Paul.
So I'm speaking as if now it is December 2021?
Yes. What went well?
Well, in the best case scenario, I'd like to think that we were able to vaccinate roughly 2/3 of the American population and get this virus largely under control. That would be the dream scenario. There's going to be a lot of stumbling, though, here, a lot of stumbling as this vaccine rolls out. At the very least, we never talk about this. There is sort of a clash of cultures between the Department of Defense and the CDC. You sort of see it happening already, but we'll see how it plays out.
Great.
I would just agree with Paul, but also to say we did that while meeting our equity goals.
Great.
I'm torn between saying that we return to evidence-based, science-driven decisions, or less cynically, that we recognize a collective action problem when we see one, right? So there are times in which it's really important to have individual rights and states' rights and autonomy, and there are times when problems are simply too big and borders are too porous among states and globally to not recognize a communal problem that requires a communal solution. So we did that.
Beautiful. Last word from the city of Philadelphia.
Well, I was going to, Paul already stole my thunder, but
He does
our measure of success is how many people do we get vaccinated? And I was going to say 60%, but I'll round up to 66 so we're consistent in what we said. But that will be ultimately what our measure of success is.
That we got that much vaccine in arms. Yeah, I think we all have enormous aspirations and hopes that this really is a route back to normalcy, and our kids can go back to school and we can gather with our families and we can get our economy back on track. Many, many equity issues to solve. There were many questions about just the vaccine itself and how long does immunity last, and should I get vaccinated if I was sick? And we're going to have to answer all those questions at the sort of tens of millions or hundreds of millions of people level. So lots of work for our frontline providers to do counseling strategies. And I'll speak as a behavioral science. I think scientists, we need the best sort of messaging and communication that emphasizes equity and access to make this all work. So thank you for your expertise and for the frontline work you're all doing in very different ways to make this vaccine happen. And I'll invite Rachel Werner back to take us out.
It was a tremendous panel. We appreciate the time that you spent here with us today, and I wish we had more time to talk. And we hope that you will continue to tune into LDI's seminars as the year goes on. Thanks, everyone, and stay safe.